Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will continue with the superior oblique palsy. In this video I will be discussing about the Knapp's classification for superior oblique palsy, which are all the various investigations you should do in a case of superior oblique palsy, and how to treat superior oblique palsy. I will be discussing both medical management as well as surgical management. So without much delay, let's begin our video on superior oblique palsy. So we have the Knapp's classification for the superior oblique palsy. This classification is based upon the hypertropia which is varying with the different gazes. So depending upon in which gaze the hypertropia is more, this classification is given. Accordingly, we have 8 types of the superior oblique palsy. So I will be taking the example of left superior oblique palsy. So this will be the patient's left side and this will be the patient's right side. So this is the dextro version for the patient and this is the levo version for the patient. So in the class 1, the hypertropia is maximum in dextro elevated gaze. So this is taken as class 1. So here there is overaction of the ipsilateral inferior oblique muscle. So there is left eye inferior oblique overaction which is leading to maximum hypertropia in the dextro version position. In the grade 2, we have the maximum hypertropia in the dextro depression position, that is in this case, and this is because of the left superior oblique underaction. In the class 3, there is uniform hypertropia in all the dextroversions, that is dextroversion and the dextro elevation and the dextro depression. The hypertropia remains same. So this is because of again left inferior oblique overaction as well as left superior oblique underaction. In the class 4, we have the hypertropia which is more in all the dextro gazes, that is dextroversion, dextro elevation, dextro depression as well as the down gazes. And here it is because of left inferior oblique overaction plus left superior oblique underaction. Along with that, there is one more component of left superior rectus contracture. Okay, so left inferior oblique overaction, left superior oblique underaction as well as left superior rectus contracture. In class 5, there is right superior rectus inhibitional palsy as well as right inferior rectus contracture. So right superior rectus inhibitional palsy as well as right inferior rectus contracture. So this concept I have explained in my previous video about the spread of comitance in the case of superior oblique palsy. So finally the patient will have right superior rectus inhibitional palsy along with right inferior rectus contracture. In class 6, there is bilateral superior oblique palsy. And in both eyes, the patient may have varied combinations of the Knapp's classification, that is from class 1 to class 5. The patient may have anything in both eyes. Coming to class 7, it is also called as canine tooth syndrome. It usually occurs secondary to trauma to the trochlear region, which is most commonly secondary to the dog bite. Okay, so here the patient will have both superior oblique and inferior oblique underaction. So the patient is having left superior oblique underaction along with left inferior oblique underaction. So this canine tooth syndrome or the class 7 of the superior oblique palsy is a DD for your Brown syndrome. We have one more classification which is added recently, that is class 8. Here the patient is having committed type of hypermetropia. That is, the hypermetropia remains same in all the gazes, but when you do the head tilt test, there is evident superior oblique palsy. So committed hypertropia with positive head tilt test. So this is the Knapp's classification from 1 to 8 with the various muscles which are involved. Next, moving on to the investigations, we have something called as FAT scan. Though this is not a radiological investigation, it is important to scan for the family album tomography. Look into the old pictures of the patients which may give clue about the onset and the duration of superior oblique palsy. If you come to the neuroimaging, it is required in case of acquired palsy. There can be brainstem lesions which leads to Perinaud syndrome, which has the component of ataxia, INO and even the Horner syndrome. Superior oblique palsy can also set in case of aneurysms of the anterior carotid artery or the superior cerebellar artery. And one more investigation which is needed is to rule out the myasthenia gravis, where there is positive hydrophonium test. So moving on to the treatment. The medical management includes the treatment of the amblyopia with occlusion therapy, and you can also use the prisms. For the amblyopia and the management of amblyopia with occlusion therapy, I have a separate video in my videos. Please do watch that for the more details. Then we can go for the prisms to treat the double vision which the patient has. Next, moving on to the definitive management, that is the surgical management. So the surgery for the superior oblique palsy depends upon to which class it will fit into. So if the patient is having class 1 type of superior oblique palsy where there is inferior oblique overaction, then the surgical management is inferior oblique weakening procedures, that is inferior oblique recession. If the patient is fitting into class 2 where there is superior oblique underaction, then the surgical management is superior oblique tack. So if the patient has both the components of inferior oblique overaction as well as the superior oblique underaction, so fitting into class 3 of superior oblique palsy, then see how much is the hypertropia. If the hypertropia is less than 20 prism diopters, then go with weakening of the inferior oblique muscle, that is inferior oblique recession on the same side. And if the hypertropia is more than 20 prism diopters, then combine both the surgeries, that is inferior oblique recession as well as superior oblique tack. So now if the patient is fitting into class 4 where there is ipsilateral superior rectus contracture along with the oblique dysfunction, then the surgical plan is along with these surgeries, that is inferior oblique weakening with the superior oblique tuck, you should also add superior rectus recession, that is weakening of the superior rectus muscle. And if the patient is in class 5 of the superior oblique palsy where there is hypertropia which is maximum in the down gazes only, along with the surgeries which I mentioned for the class 4, that is inferior oblique recession or superior oblique tuck or the superior rectus recession, along with that we will have to do inferior rectus recession. If the patient is having bilateral superior oblique palsy that is fitting into class 6 of Knapp's classification, then depending upon which class the each eye is, the surgical procedure can be planned. And if the patient is in class 7, that is the canine tooth syndrome, then you will have to explore the trochlear area. Okay, so explore the trochlear area for any anomalies and treat that. In case of class 8 where there is committed hypertropia with positive head tilt test, then consider combination of all these, that is inferior oblique recession or superior oblique tuck, superior rectus contralateral superior rectus recession or contralateral inferior rectus recession. So these are the various procedures for superior oblique palsy. Then moving on to one more important surgery in case of superior oblique palsy, that is HARADA ITO procedure. Okay, so the HARADA ITO procedure is done in case of bilateral superior oblique palsy where there is a cyclotorsion of more than 10 degrees. Here just the bilateral weakening of the inferior oblique muscle is not enough to tackle the cyclotorsion component. So we will be splitting the superior oblique muscle and then doing the procedure. As you all know, the superior oblique muscle has a fan-shaped insertion. The anterior fibers are responsible for the torsional component of the action of the muscle, and the posterior fibers of the superior oblique is responsible for the vertical action of the superior oblique muscle. So here in the HARADA ITO procedure, we are splitting this superior oblique muscle into the anterior and the posterior components. These anterior fibers are advanced to the superior border of the lateral rectus muscle. They are inserted onto the sclera about 8 mm posterior to the lateral rectus insertion. That is, so this is the eyeball. So we have the lateral rectus here. So we have the lateral rectus here and the superior oblique muscle which was inserting like this. So we will be splitting this muscle into the anterior and the posterior component. So these anterior fibers are secured onto the sclera about 8 mm away from the insertion of the lateral rectus muscle. Okay, so this is HARADA ITO procedure to tackle the torsional component in case of bilateral superior oblique palsy. So hope this video on the Knapp's classification of superior oblique palsy along with the management aspect, which includes both investigations, the medical management as well as the surgical management, with a note on HARADA ITO procedure, helpful to all of you. If you like my videos, please do subscribe to my channel, press the bell icon for further notifications. Please do like and share my videos and leave your valuable comments. Thank you so much.